The topic of the tutorial is scalp, and I, Dr. Alpana Kesar, will be covering this topic under the following subheads: layers of the scalp, innervation, blood supply of scalp, and its lymphatic drainage. This is the visual of the skull. This part is the skull cap. Skull cap is also known as cranial vault. Soft tissue that covers the cranial vault, that is, skin, connective tissue, and the muscles, is called scalp. Scalp include forehead part of the face and the head region. This is the supraorbital margin, and just above the supraorbital margin, arch elevations are known as the superciliary arches. Posteriorly, this is the external occipital protuberance, and these are the superior nuchal lines. This is the superior temporal line on the lateral surface of the skull. The extensions of scalp is from the supraorbital margin and the superciliary arches anteriorly to the external occipital protuberance and the superior nuchal lines posteriorly. Laterally, the extension is from the superior temporal lines on one side to the superior temporal lines on the other side. Scalp is a multi-layered structure. Scalp comprises of 5 layers. The letter scalp itself acts like a mnemonic for the name of each of the layers. The outermost layer is skin. Deeper to that is present connective tissue dense. The third layer is the aponeurotic layer. The fourth layer is loose connective tissue, and the fifth layer is pericranium. Skin is the outermost layer which we can see and feel. In our body, just beneath the skin is present loose connective tissue. An exception to that is scalp, where we have dense connective tissue beneath the skin. Also in palms and soles, we have dense connective tissue beneath the skin. The third layer is the aponeurotic layer, which comprises of muscles and aponeurosis. The fourth layer is loose connective tissue, and the fifth layer is pericranium, which is same as periosteal covering of the bone. Skin. Skin is the outermost layer of scalp which we can see and feel. Histologically, the skin of the scalp is made up of stratified squamous keratinized epithelium of thin type. This is similar to the skin in the rest of the human body except for palm and sole, which has thick skin. Some differences between the skin of the scalp and the rest of the body are: the skin of the scalp has numerous hair follicles and associated sebaceous glands. Sweat glands in the skin of the scalp are more numerous. The hair in the scalp grow longer as compared to the rest of the body, where the hair remains short. This is so because in the scalp, the anagen or the growth phase lasts for 2 to 7 years as compared to the rest of the body, where the anagen phase lasts only for a few weeks. The second layer of scalp present beneath the skin is dense connective tissue. In human body, beneath the skin is present loose connective tissue, with scalp, palms and soles being an exception that have dense connective tissue present beneath the skin. Dense connective tissue layer helps skin to be tightly adhered to the third layer, that is the aponeurotic layer. So when we move the skin of the scalp, we move all the three layers, that is skin, connective tissue and aponeurotic layer, as a single entity, and these three together are known as scalp proper. This layer contains the arteries, veins and nerves that supply the scalp. The layer of dense connective tissue has blood vessels traversing through it, and the fibers of dense connective tissue layer are adherent to the walls of the blood vessels. When the blood vessels are cut in the wounds of the scalp, the fibers of this layer will tend to hold the cut end of the vessels open, leading to profuse bleeding. Thus, scalp wounds bleed profusely. Moreover, the dense connective tissue present in the second layer prevent the cut ends of the wound from retracting, which causes the wounds of the scalp to gape. Thus, the wounds of the scalp must be sutured to control the bleeding. The third layer of scalp is called the aponeurotic layer. It is also called epicranial aponeurosis or Galea aponeurotica. Before we go into the details of this layer, let us try to understand what is aponeurosis. A muscle is inserted into the bone with the help of tendon. In flattened muscles, the tendons are also flattened and they are known as aponeurosis. The third layer of scalp consists of aponeurosis with frontal and occipital bellies of occipitofrontalis attached to it. The frontal belly of occipitofrontalis muscle arises from the skin of the eyebrows. The muscle fibers pass upwards and become continuous with the epicranial aponeurosis. The occipital belly of occipitofrontalis takes origin from the superior nuchal lines and from the mastoid process. The muscle fibers pass upwards and become continuous with the epicranial aponeurosis. The action of occipitofrontalis muscle is to move the scalp. It helps to wrinkle the forehead and also raise the eyebrows. We must understand that the fibers of occipital belly are very less. Comparatively, the frontal belly is much larger in size, and whatever movement that takes place in this layer mostly occurs by the contraction of the fibers of frontal belly. The innervation of the muscle is the frontal belly is innervated by temporal branches of the facial nerve, and the occipital belly is innervated by the posterior auricular branch of facial nerve. The fourth layer of the scalp is the layer of loose connective tissue. This layer separates the aponeurotic layer from the pericranium. This layer also facilitates the movement of scalp proper over the calvarium. The fourth layer, or the layer of loose connective tissue, contains the nerves and the blood vessels. It provides passage to the emissary veins. Emissary veins help in connecting the extracranial veins with the intracranial dural venous sinuses. Previously, we have seen that the frontalis muscle has no bony attachment. It is only attached to the skin of the eyebrows, and thus the loose connective tissue layer of the scalp is continuous into the eyelids. This is the fourth layer of the scalp. It is also called the dangerous layer of the scalp. This is so because the emissary veins open here. The emissary veins are those veins that help in connecting the extracranial veins with the intracranial dural venous sinuses. The significance of these veins is that whenever there is rise in the intracranial blood pressure, the blood will flow from the intracranial veins through the emissary veins into the extracranial veins. This will help in reducing the intracranial blood pressure. Emissary veins are valveless veins, and so the blood can flow in them in either direction. The blood will not only flow from the intracranial veins to the extracranial veins, but the blood can also flow from the veins in the scalp to the intracranial veins. If there are any infections in the scalp localized in the fourth layer, it can easily travel through the emissary veins into the intracranial veins, thus infecting the intracranial dural venous sinuses that may even result in intracranial venous thrombosis. Thus, the fourth layer of the scalp is called the dangerous layer of the scalp. The cerebral venous thrombosis is usually associated with clinical symptoms like the isolated intracranial hypertension, associated with headache, vomiting, and visual symptoms, motor and sensory deficits, onsets of seizures, and global encephalopathy. Frontalis muscle in the region of the forehead does not have any bony attachment. The loose connective tissue layer or the fourth layer of scalp is thus continuous with the connective tissue layer of the eyelids. If there is accumulation of blood in the fourth layer of scalp due to ruptured blood vessels, the blood can gravitate to the eyelids, causing a black eye. Pericranium is the fifth layer of the scalp. It is the deepest layer of the scalp. It is same as the periosteum, present on the outer surface of the calvarium. It is loosely attached to the surface of the bones but firmly adherent at the sutures. Whenever there is accumulation of blood or fluid beneath the pericranium, it will take the shape of the underlying bone. Such a condition is known as cephalohematoma. Students, don't forget to like this video and subscribe to the channel to stay updated with the latest exam questions. Innervation or the nerve supply of the scalp. The sensory innervation are those nerves which carries the sensation of touch, temperature and pain from the scalp. It is divided in two parts. The anterior half, which gets its sensory innervation from cranial nerve, specifically from the fifth cranial nerve or the trigeminal nerve. The posterior half of the scalp gets its sensory innervation from the cervical spinal nerves. The motor innervation of the scalp or the nerve supply to the muscles of the scalp. The occipitofrontalis muscle is innervated by branches of facial nerve. Sensory innervation of the anterior half of the scalp is by branches of trigeminal nerve. There are three branches of trigeminal nerve that supply the anterior half of the scalp. They are ophthalmic nerve, maxillary nerve, and the mandibular nerve. Ophthalmic nerve supplies the anterior part of the scalp through its two branches, supratrochlear and supraorbital. Supraorbital is a much larger branch as compared to supratrochlear. Supratrochlear is a branch which is close to the midline, while supraorbital is lateral to it. Supratrochlear supplies the anterior part of the forehead, while The supraorbital supplies the forehead and the anterior part of the scalp as far as till the vertex. The zygomaticotemporal branch is a branch of maxillary nerve which supplies a small area of the scalp over the region of temple. A large lateral part of the scalp over the temporal region is supplied by the mandibular division of trigeminal nerve through its branch called auriculotemporal. So the four branches of trigeminal nerve are supratrochlear, supraorbital, zygomaticotemporal and auriculotemporal, which are responsible for sensory nerve supply to the anterior half of the scalp. The posterior half of the scalp gets its sensory nerve supply from the second and the third cervical spinal nerve. The second and the third cervical spinal nerve supply the posterior half of the scalp through its four branches, namely great auricular, lesser occipital, greater occipital, and third occipital. The great auricular receives the anterior rami of C2 and C3 cervical spinal nerves. It supplies a small area of scalp just posterior to the ear. The lesser occipital nerve receives the anterior ramus of the second cervical spinal nerve and supplies the area of the scalp posterior and superior to the ear. Greater occipital nerve receives the posterior ramus of the second cervical spinal nerve. It supplies a large part of the posterior surface of the scalp. It supplies the occipital region of the scalp as far as till the vertex. Third occipital nerve is a small branch that receives posterior ramus of the third cervical spinal nerve and supplies a small area in the lower part of the posterior surface of scalp. Blood vessels of the scalp. The arterial blood supply of the scalp is by branches of both the external and the internal carotid arteries. The five arteries that contribute to the blood supply of the scalp are supratrochlear, supraorbital, superficial temporal, posterior auricular, and occipital arteries. Supratrochlear and supraorbital are branches of ophthalmic artery, and ophthalmic artery is a branch of internal carotid artery. Supratrochlear is a small branch close to the midline and supplies blood to the medial region of the forehead. Supraorbital is more laterally placed and much larger artery as compared to supratrochlear and contribute to the blood supply to the forehead and the anterior part of the scalp as far as till the vertex. Superficial temporal artery is a branch of external carotid artery. It is rather a terminal branch of external carotid artery and supplies blood to entire lateral aspect of the scalp. Posterior auricular artery is a smaller branch of the external carotid artery and contributes to the blood to the area of the scalp just behind the ears. Occipital artery is a branch of external carotid artery that supplies blood to the posterior aspect of the scalp in the occipital region. Through these 5 arteries, scalp gets a rich blood supply. Venous drainage of the scalp. 5 veins drain blood from the scalp. They are supratrochlear, supraorbital, superficial temporal, posterior auricular, and the occipital veins. These veins drain the same area which is supplied by the arteries that they accompany. That is, supratrochlear and supraorbital drains blood from the anterior part of the scalp. Superficial temporal vein drains blood from the lateral aspect of the scalp. Posterior auricular from a small area behind the ear, and occipital vein from the occipital region of the scalp. After draining blood from the scalp, the veins will follow the following course. The supratrochlear and supraorbital will join at the medial angle of the eye to form the angular vein. The angular vein descends down in the face as the facial vein. The superficial temporal vein will descend down where it will be joined by the maxillary vein to form the retromandibular vein. The retromandibular vein divides into its anterior and posterior tributaries. The anterior tributary joins with the facial vein to form the common facial vein, and common facial vein terminates in the internal jugular vein. The posterior division of the retromandibular vein joins with the posterior auricular vein to form the external jugular vein. The occipital vein, which drains the occipital region of the scalp, terminates in the suboccipital venous plexus. Emissary veins. Veins of the scalp are those veins that drain blood from the scalp. Emissary veins is yet another type of veins present in the scalp. Emissary veins are those veins that connect the veins of the scalp with the intracranial dural venous sinuses. The function of emissary veins is whenever there is increase in blood pressure in the intracranial dural venous sinuses, blood can flow through emissary veins into the extracranial veins. This helps in normalizing the blood pressure inside the intracranial veins. Emissary veins are valvulus veins, which means blood can flow in either directions. If there are any infections localized in the layers of scalp, it can easily travel through the emissary veins to the intracranial dural venous sinuses, since the blood can flow in both the directions. This can infect the veins inside the cranial cavity, leading to venous sinus thrombosis. The two emissary veins that are present in the scalp are the parietal emissary vein that passes through the parietal foramen to the superior sagittal sinus. Second one is the mastoid emissary vein, which passes through the mastoid foramen to the sigmoid sinus. Lymph nodes of the scalp. Before we do the lymph nodes of the scalp, let us try to understand what is lymph. Interstitial fluid enters the lymphatic vessels and becomes the lymph. The lymph then flows through the lymph nodes where the filtration of lymph takes place. From there, the lymph enters into bigger lymphatic vessels to reach yet another group of lymph nodes where the filtration of lymph takes place again. The lymph nodes present in the region of head are the occipital group of lymph nodes, mastoid group of lymph nodes, parotid group of lymph nodes, submandibular lymph nodes, and submental lymph nodes. The occipital lymph nodes are present in the occipital region. The mastoid lymph nodes are present in the mastoid region around the mastoid process behind the ears. The parotid group of lymph nodes is present in front of the ears around the parotid gland. The submandibular lymph nodes is present in the submandibular region, and submental lymph nodes is present below and behind the chin. The occipital lymph nodes drain lymphatics from the occipital region. The mastoid group of lymph nodes drain lymph from the upper part of the scalp posterior to the vertex of the head. Parotid group of lymph nodes drain lymph from the upper part of the scalp anterior to the vertex of the head. And submandibular lymph nodes receive lymphatics from the region of forehead. The lymph from these lymphatic nodes then enter bigger lymphatic vessels to reach the deep cervical group of lymph nodes. Deep cervical group of lymph nodes are those lymph nodes which are present along the internal jugular vein. These lymph nodes are further divided into two, the upper deep cervical lymph nodes and the lower deep cervical lymph nodes. The most prominent lymph node in the upper deep cervical lymph nodes is jugulo-digastric lymph node, and the most prominent lymph node in the lower deep cervical lymph nodes is jugulo-omohyoid lymph nodes. The lymphatics from all the lymph nodes in the scalp will flow into these deep cervical group of lymph nodes. Clinical anatomy of scalp. In the scalp, hair follicles and sebaceous glands are present in abundance. Hence, scalp is a common site for the formation of sebaceous cysts. Whenever there are injuries in the scalp and parts of scalp gets avulsed, then they need not be cut away. When the avulsed portions of scalp are replaced and sutured back, it will heal well. It is so because scalp has a rich blood supply. Wounds of scalp bleed profusely. It is so because the dense connective tissue present around the walls of the blood vessels prevent the cut end from retracting. Moreover, in the scalp wounds, the bleeding is arterial as venous pressure is low in scalp in erect posture. Bleeding from a cut in the scalp can be arrested by applying pressure on both sides of the cut. Further, cuts in the scalp must be sutured to arrest bleeding and aid in healing. Extracranial infections can spread to intracranial dural venous sinuses through emissary veins, which are present in the fourth layer of the scalp. Hence, this layer is also called the dangerous layer of the scalp. Infections of the second layer of dense connective tissue causes little swelling but severe pain because of numerous collagen fibers. Accumulation of blood in the fourth layer of scalp of loose connective tissue causes generalized swelling of scalp. The blood may even flow anteriorly into the upper eyelid causing black eye. Accumulation of blood below the pericranium is known as cephalohematoma. It takes the shape of the underlying bone because the pericranium is loosely adherent to the surface of the bones but tightly adherent at the sutures. Important exam questions from the topic scalp are: enumerate the layers of scalp, briefly describe the layers of scalp, blood supply of scalp, innervation or nerve supply of scalp, which is the dangerous layer of scalp and why, A short note on black eye. Very short notes on why is scalp a common site for the sebaceous cyst? Why are wounds of scalp sutured? Why do wounds of scalp bleed profusely? Why do scalp wounds heal fast?